Alaikum students. So today we will be talking about examination of the motor system. I hope voice is clear and screen is shared with you. Uh, we initially give the topic of introduction, history taking and localization, but we were told that there are only 5 lectures which neurology department has to take. So we decided to concentrate more on examination so that you should know how to examine a patient with neurological disorder. So, starting with our next lectures would also be based on basically how to conduct the neurological examination. And whenever and any one of you wants is more interested in doing the practical examination, they are always welcome to visit Department of Neurology either here or in OJA. And our two faculty members will be able to facilitate you uh, uh, how to conduct the examination physically. Uh, so we will be talking about motor system. Motor system is that system. By motor we means movement. So what this system generates movement of limbs and all other parts of the body. Whatever moves in the body comes under the system of motor system. Motor system has two functions. It not only generates these movements, but it also uh, stabilizes these movements. So in central nervous system, we have 3 levels of motor control. The highest control is through cerebral cortex, then through brainstem, and then through spinal cord. And you all know that cerebral cortex has this representation of all parts of the body, and which will help you understand that how movement is the highest level of control of movement is governed through this cerebral cortex. It has representation of each and every part of your body, and it controls so we call it motor homunculus. Then brainstem has 3 parts, and it has midbrain, pons, and medulla. As you all know. And then spinal cord, we have inferior horn cells, which are topographically arranged, medially located anterior horn cells. They innervate proximal muscles, and laterally located uh, anterior horn cells. They control ventral horn cells. This has important implication when we are seeing syndromes which either arise intrinsically from the cord, or which when the spinal cord is being compressed from outside. So this has importance. Then besides this control, this is how the motor movement is generated. But there are two important centers which act on all the movements and cause them to become smooth and target oriented. For example, a person may overshoot or undershoot if the cerebellum is not working. You all know that ataxia or imbalance occurs if the cerebellum is not functioning. So cerebellum modulates the range of movement, and it makes the movement target oriented. Basal ganglia are responsible for smoothness of the movements. They remove jerks and the other type of superimposed activity on any voluntary movement, and that is how we all know that if basal ganglia are not if basal ganglia are diseased or if not functioning properly, movement disorders appear. So we have 3 level of controls: cerebral cortex, brainstem, and spinal cord, and the motor modulators, which are cerebellum and basal ganglia. Each have their functions, and each of them have their signs and symptoms if they are diseased. Uh, how can we pick up those dysfunctions and those disorders if they are present, or if they are when the patient comes to you, for example, with loss of movement, with hemiplegia, for example, with loss of movement, weakness of paralysis of muscles, how will you identify that disorder? And You can identify those disorders if you know uh, if you know that uh, how these movements, how these how the what is the normal examination of the system. So what are the major manifestations? How will a patient present to you with motor dysfunction? So we divide them into positive functions and we divide them into negative dysfunction. More negative dysfunctions are more common. Negative when the movement, when there's loss of certain function. So when there's loss of motor function, we call it weakness or paralysis. When there's loss of muscle mass, we call it wasting. When there's loss of reflexes, we call it areflexia. When there's loss of speech or language, we call it aphasia. When there is loss of voluntary activity, we call it apraxia. And when there's loss of balance or coordination, we call it ataxia. So what are positive dysfunctions are when there is superimposed something which is normally present, but which is normally not present, but when a thing is diseased, when some organ or some part of the central nervous system is diseased, these symptoms appear. They are added symptoms or added signs which you can identify when you are examining a patient. Spasticity. Spasticity is increased tone. Rigidity, again, an example can be. Fasciculations are involuntary, small movements, rippling movements in the muscles. Then movement disorders or abnormal movements like tremors, chorea, bellesmus, all that you see, and then seizures. So all the all of these movements, we divide them into negative and positive symptoms. And whenever a patient comes to you with these symptoms, uh, we uh, we classify accordingly and we examine accordingly. So most of you know must be knowing already when you went through your physiology lectures or anatomy lectures that what what upper motor neurons are and what lower motor neurons are. So upper motor neurons are in the precentral gyrus of the frontal lobe, and they in all the descending pathways of the brain and spinal cord involved in voluntary activity of the muscles. They are upper motor neurons. Lower motor neurons are brainstem, spinal cord neurons, and they're issuing cranial and spinal nerves. How do you differentiate is also known to you all of known to all of you. Upper motor neuron, they cause flaccidity. Upper motor neuron weakness causes spasticity. Decreased tone, areflexia or hyperreflexia, muscle atrophy or wasting, and fasciculations are usually present in lower motor neuron disorders. Uh, the, just opposite, the tone is increased when we consider upper motor neuron disorders. Hyperreflexia is also seen. There is muscle atrophy is there, but that is much less than that seen in lower motor neuron disorders. And fasciculations are usually absent in upper motor. How do we uh, how many types of weakness, patterns of weakness we see this? So we can see monoplegia when there's only one limb affected, diplegia when there are two limbs are affected, paraplegia when both lower limbs are affected, hemiplegia when one side of the body is affected, half of the body is affected, and quadriplegia when all four limbs are affected. This is how we describe paralysis. Then we also think in terms of proximal and distal weakness. For example, muscle myopathies, they give rise to proximal weakness more commonly, and neuropathies which give rise to distal weakness. Proximal weakness means weakness around girdles, shoulder girdle or thigh girdle. Shoulder girdle or thigh, for example, shoulder girdle is weaker than hand movement, and uh, thigh or hip girdle muscles are weaker than the muscles of the foot. Then we again divide into spastic or classic weakness, as we talked earlier. depending on whether weakness is upper motor neuron type, it is spastic. When it is lower motor neuron type, it is flaccid. So how do we start examination of the motor system? There's an there's an in all universal consensus that we examine the motor system basically in the forehead. We look for bulk, which is seen on inspection, and you can also palpate the muscles of the exam when you are examining. Then we look for tone, and then we look for strength, and then finally, then we reflexes. So, there are certain other general rules. You should always be standing on the right side, and you should be starting the exam. You should be starting the examination on the right side. Uh, each test each side independently, and then continue to compare the two sides of the body to a certain symmetry. Sometimes weakness is very subtle, or change in tone is very subtle. If you do not compare with the other side, you won't be able to find out the difference between the two sides. So it is always necessary to compare the two sides when you are performing the test on one side. It is necessary to perform the test on the opposite sides also. So to look for symmetry, other observations include symmetry, bulk of muscles right and left, distal and proximal. Sometimes muscles are more wasted distally than proximally, or they may be more wasted proximally than distally. Sometimes wasting is more on right and left, also, and there are certain disorders which are global, like for example peripheral neuropathy. In symmetrical peripheral neuropathy, diabetic neuropathy, you usually find symmetrical wasting and weakness on the two sides. But in hemiplegia, you see weakness one side on the then on the other side. Then you also look for fasciculation while you are observing, and you also look for involuntary movement. You also look for skin formations. To begin your examination, as you can see that this man is holding out his hands, is holding out his upper limb. This is called arm drift. You ask the patient to hold out their arms in extension and supination. You must ensure that elbows are extended completely. If there is some disease, and you ask the patient to close their eyes. And how do we interpret this test? When the patient is in this position, normal response is the arms remain in the same position in which you ask the patient to, and there is no displacement of the arm. We call pronator drift when the arm drops lower than the normal arm. One arm drops and the other arm stays in the same. And elbow flexes and hand pronates. We call it pronator or pyramidal tract. It is usually seen in pyramidal tract or upper motor neuron region. Then parietal drift, affected arm moves upwards and outwards. It is seen in parietal lobe lesions due to loss of joint position sense. Uh, Parietal lobe is associated, as you can see, as you remember, motor homunculus is situated in the frontal lobe at, at the interior border of the sentence fissure, and the other is situated behind the fissure. So see it, this that is since it is behind the fissure, it is a part of motor homunculus. Sorry, sensory homunculus is a part of parietal lobe. So when there's loss of joint position sense and there are loss of cortical sensations, you can see that the patient is not able to maintain his arm again in this position. So in the first instance, in pyramidal tract, the arm drop is due to weakness, and here it is due to loss of joint position sense. Then cerebellar drift, arm moves upwards and outwards. Here it pronates, and here it moves upwards, and when it wanders, it may not stay in one place. So, and if you tap the arm, there is overcorrection, which we call rebound phenomena. Okay? Um, I'll show you. If you tap on the outstretched arm downward, for example, if you little go in the downward direction, the arm may shoot for upward. I have also I have also provided links of examination during of these examination at the end of the video. So tone uh, after inspection or after this arm drift, we come first to the tone. Inspection during inspection we also look for muscle tone, muscle bulk and wasting. Then we come to tone. Tone is the resistance which you appreciate when moving a limb passively. Tone may be normal, may be reduced, which is called hypotonia, or it may be increased, which is hypertonia. Hypotonia is basically reduced feeling of reduced resistance, but hypertonia is increased resistance and maybe rigidity or spasticity. So you examine tone at all these levels. You examine tone at shoulder joint, at forearm or elbow, in hand, at wrist. Then in lower limb, you examine tone at hip joint, at uh, for thigh and leg and foot. So these are this is how we rest the patient. This is how tone is examined at the wrist. Rest the patient hand and support their elbow and ask the patient to relax and take and ask the patient to relax completely. Relaxation is very important and you must inquire about whether there's any pain or any joint involvement which may limit your movement or you may cause any harm to the patient. So it must always be asked before starting your examination that if the patient is feeling pain, that you must be careful in examining those parts of the body. At wrist, you do circumflexion. At elbow, you do flexion and extension, not only flexion, but also supination and pronation. At shoulder joint again, you do circumflexion. Circumflexion is rotatory movement. You at wrist also you do rotatory movement, and at shoulder you also do rotatory movement to look for the toe. I am quite aware that it is difficult to teach examination online, but we can provide you videos and we can also invite you to our department to look for these signs whenever you have confusion. I know it is very difficult if you haven't seen these examinations before. It is very difficult to teach or to learn these examinations solely online. Then in while examining the patient by a tone in lower limb, you ask the patient to lie comfortably on the couch and ask the patient to relax. Roll each leg to assess the tone in the muscles. Lift each knee briskly off the bed and observe the movements of the legs. In patients with normal tone, the knee rises and heel remain in contact with the bed. In when the tone is increased, the heel typically lifts off the bed, and then there's increased tone. Then we also look for ankle tonus. Then how to test muscle strength? Muscle strength is tested by having the patient move against your resistance, against your power. You always compare one side onto the other. Muscle grade strength is measured on MRC scale from 0 to 5 or out of 5. So this is MRC scale for grading muscle strength. Uh, we must first know what are grades of movement. 0 is no movement, no muscle movement at all. 1 by 5 is visible movement, but no movement at the joint. There's flicker, but no movement at the joint. It does not displace the joint. Two movement, the 2 by 5 is movement at the joint, but your patient cannot move it against gravity. Then patient can move, 3 by 5 is patient can move it against gravity, but cannot move it against resistance. Then 4 by 5 is it can move against resistance, but less than normal. For example, if you are putting downward pressure on your patient, on the muscles of your patient, you can feel the resistance, but patient will not be able to overcome your resistance or your power. Then 5 by 5 is normal strength. Patient is able to overcome your resistance or is equal to your power. So we again examine these at shoulder joint, in upper limb at shoulder joint, at elbow joint, at wrist, and at the small joints of his hands. Then we also in lower limb we examine it at hip joint, knee joint, and ankle joint. So this is how we examine shoulder abduction and shoulder adduction. For shoulder abduction, which is you ask the patient to flex their elbows and abduct their shoulders at right angle to their body. You can see the elbows are flexed and shoulders are abducted at right angle. Uh, this is you apply downward pressure around, place your hands around their elbows and apply downward pressure on the arm and ask the patient to maintain their posture and not let you push their shoulder down. This, if the patient is able to maintain this pressure, power is normal. And if the patient is not, if the power is less than 3 by 5, then patient won't be able to raise their or hold their arms in this position. If power is less than 3, if power is 3, patient will not be able to resist your pressure at all. If the power is 4, they will be able to resist your pressure a little, but they won't be able to overcome your pressure. And if the power is 5, they may either overcome your resistance or you and the patient become static at a certain level. Same when you are checking shoulder abduction. In checking abduction, you put your hands above the elbow, and here you put your hands below the elbow and ask the patient to push downward. Uh, then checking strength, ask the patient to put their forearms up, flex their elbows, and stabilize their shoulder. Apply pressure to pull the forearm towards yourself. This is this is your checking elbow flexion. If the patient is able to overcome your resistance, his flexion is normal. Then you for checking uh, elbow extension, you apply pressure on the outside of the on the extensor surface of the forearm and ask the patient to push it downwards or towards you. While checking flexion, patient is pulling the forearm towards himself, and when you are checking extension, the patient is checking it, pushing it or forcing it towards you. Then strength asks the patient to sort of uh, make a fist and extend their wrist. This is flexion of the wrist joint, and you ask the patient flex it. Sorry, this is extension, and you ask the patient to extend their wrist, and this is flexion of wrist. Here you can see this is flexion of wrist, and this is extension of wrist. Uh, Ask the patient to extend their wrist joint and apply down the pressure, and ask them not to let you pull it down. Then for a wrist extension, ask the patient press their wrist joint and apply pressure, and ask them not to let you push it down. So these are the positions in which you check for. This is checking. This is extensor surface uh, of the arm, for the forearm and wrist, and you are applying pressure on the wrist. So you are applying to push the wrist downward, but the patient is applying to push it backward or extending the wrist. Here you are applying to extend the wrist. You are applying pressure in the upward direction, but the patient is applying pressure in the downward direction to uh, flex the wrist. Uh, Similarly, we check for uh, finger extension. You put your hand on the extensor surface of the or the dorsum of the hand of the dorsum of the fingers and ask the patient to push it upward. And here you for flexion you ask the patient to grip your. So only checking for grip, which is common understanding, is not checking for the strength of the whole upper limb. Then coming to lower limb. Uh, Coming to lower limb, you ask a patient to raise their legs off the back or elevate flex knee when in sitting. When the patient is on bed, you ask them to raise their leg off the bed, and when in sitting, you ask them to elevate flexed knee. This is how you look for hip flexion. If the patient is again, you are applying your pressure downward and the patient is applying pressure in upward direction. For hip extension, you put your hands behind me and similarly here behind me, and you ask the patient to push downwards. And this is how you are checking uh, for hip flexion. This is our end-to-end flexion and extension. Then how to check strength at knee? You ask the patient to stabilize the knee joint and ask the patient to strengthen their legs. And you are applying pressure and not letting the patient extend their knee. This not strengthen their legs. Apply pressure, knee flexion, knee extension. First picture is knee extension. You put your hand on the interior portion of the lower limb and ask the patient to try and straighten their leg against your force. Similarly, you put your hand behind on the calf muscles, and this is knee flexion. You ask the patient to flex their knee and you are applying pressure to extend the knee upward. Your force is outward, here your force is inward. So this is how you check for. Uh, then again, strength checking at your ankle. You ask the patient to dorsiflex their foot, apply pressure on dorsum of foot and push it down. And ask them to pull their foot upwards against your resistance. You ask the patient to pull their face upwards towards their face or towards their body. And here for to check for plantar flexion, you ask them to push them with their feet downward, and your pressure is in upward direction. Here your pressure is in downward direction. So every time the muscle you are checking, you're applying your pressure against the action of that muscle, against the normal action of those muscles. Your pressure should be opposite to the normal action of the muscles. Then uh, for deep tendon reflexes, the rules must be that patient must be relaxed. It is difficult to elicit the reflexes when the patient is stressed, or sometimes you get hyperreflexia when the patient has anxiety. And the limbs must be positioned properly before a start. Reflex response depends on the force of your stimulus. You should not you, you should use no more force than you need to provoke a definite response. This you learn with practice. You must learn handle the tendon hammer and must know how to apply, how much force to apply. Otherwise, if too much force, you may hurt your patient. If too little force, response may not be elicited. So, muscle is expected to contract, and the muscle expected to contract should be exposed or palpate. For example, if you're palpating, if you're eliciting thigh muscles or knee jerk, then thigh muscles should either be exposed or your hand should be placed on the thigh muscles to look for contraction or the strength of the response or the contraction of the muscles. Reflexes again should be checked first on right and then on left. Reflexes can be reinforced by asking the patient to perform certain isolatory contraction of their body. If the patient is not able to, this is how you grade your reflexes. Uh, 0 is absent, 1 is hyperactive, 2 is normal, 3 is hyperactive without clonus, and 4 is hyperactive with clonus. This is how you classify or record your reflexes. This is twin square hammer, which we commonly use. It is it is held at a junction of it is held at a uh, junction of upper third and uh, lower one third, lower one third, and upper two third. It is hold here. Doctor has to hold this hammer here, and it should always strike perpendicular to the hammer. It should be passively swung with gravity assistance to strike onto the tendon. I'm sorry I could not find pictures with people performing with Quentin square, which we commonly use in our clinics. Pictures were available with this type of hammer, which we commonly do not use in our clinics. So here are marks where to check for bicep reflex. You place your finger here. You palpate for the biceps tendon here. Locate the bicep tendon, place your thumb and tap your thumb with the tendon hammer. You do not directly tap. There are certain places where you do not directly tap the tendon. Place your thumb, feel the tightness of the tendon, and then what you look? You look for contraction of the biceps muscle. If the biceps muscle contracts, what happens? The arm flexes. So you look for flexion of the arm and you look for contraction of the biceps muscle. This is the side, and this is the side where you look for supinator. Uh, with this uh, with this hammer, it can be struck directly, but with uh, all other hammers, you again have to place your fingers here at this point at the supinator tendon. Uh, place first two fingers of your non over the tendon, and then tap your fingers with the tendon. You do not directly tap this tendon, as the biceps muscle contracts.
Hello? Okay. हेलो।
हेलो।
यस मैम, नेट चला गया था।
ये कैसे हो गया था?
वो मैम आपकी तरफ का मैडम
हेलो।
शायद नेट चला गया था। मैम नेट चला गया था आपकी तरफ का।
अच्छा।
जी जी जी।
अच्छा।
मैम स्टार्ट कर दीजिए आप।
स्टार्ट कर रही हूँ, देखिए हमने काम को छोड़ा था। आई डोंट नो, ये कैसे पता चलेगा कहाँ तक चला था?
मैम यहीं तक था आपका।
नहीं तक था। अच्छा, so to resume, we locate the brachioradialis tendon, and here it is located. As you know your surface anatomy, and you apply and you place first two fingers of your non-dominant hand over the tendon, and tap your finger with the tendon hammer, and you observe for the contraction of the bicep of the brachioradialis muscle, and it causes associated flexion and supination of the forearm. So what you look for supination of the forearm uh, with this thing. Then rest the patient's elbow against your arm, and ask them to lose their hand, to hang their hand loosely, and or you support rest the, or support on their lap, and ask the patient's arm to form a right angle at the shoulder to relax triceps tendon. Locate the tricep tendon. It is located just above the elbow, and you tap the tendon with the tendon hammer. Here, the hammer is stuck directly over the tendon, and you do not have to place your fingers on the tendon. Uh, Ask the patient to flex their knee or to look for knee jerk. We ask the patient to flex their knees at the legs at knee. Relax the lower limb by either supporting it behind me, or ask the patient to hang their legs over the side of the side of the bed. Feel for patellar tendon. Place your non-dominant hand on the quadriceps muscles if you cannot expose it, and look for the contraction. Uh, Tap the patellar tendon with the tendon hammer. Gain directly. In upper limb, we do not uh, tap biceps and supinator tendons directly. We place their fingers and tap on them. But for triceps jerk, for knee jerk, and for ankle jerk, we tap the tendons directly without placing it, without using our fingers. But you can place your hand on the quadriceps muscles to feel for the contraction. Contraction of the क्या what does it do? Uh, Contraction of the quadriceps, it causes knee to extend. So uh, that is why, and you must be standing on the side, otherwise the patient may hit you with his, depending on the response. Uh, then ankle jerk can be done with the patient seated and the feet dangling over the edge of the bed, or lying, crossing the leg over the other. Identify the tendocalcaneus. This is tendocalcaneus, the most strong tendon in the body. So position the foot so that it forms a right angle with the rest of the lower limb. You can see it forms a right angle. You give this is how you are when the feet is dangling, the foot also drops down. But you have to place the foot in a position where it forms a right angle. This is how you are stretching the tendon a little. Um, Strike the tendon directly with your reflex hammer and look for contraction of the calf muscles. When the calf muscles contract, the knee plantar flexes. The foot plantar flexes. So this is how you either you look for contraction of the calf, or you look for the plantar flexion of the foot. Uh, what do you do when the reflexes do not appear with or the reflexes are weak or do not appear? To ensure that this reflex is absent, we reinforce the reflex arm. This is done either by voluntary contraction of muscles anywhere in the body. This increases the sensitivity of cranial reflexes. The procedure is known as Jalaresic's maneuver. To reinforce, ask the patient to either clench their teeth or grasp it. To clench their teeth when you are examining reflexes in the upper limb, or to grasp their hands together and pull apart, just as you can see in this picture. You ask the patient to hook their hands together and pull apart to look for weak reflexes in lower limb. For upper limb, you ask them to clench their teeth. Finally, plantar reflex. If you have to stroke, do not stroke on this soft part of the foot. It is painful for the patient. So strike any blunt object, preferably key or something like that, and apply little pressure and ask and move in this direction and ask the patient to uh, and look for the response. Normal response is flexion of all toes. Abdominal response is extension of all toes. And this extension of big toe and fanning of all these toes. So this is again an upper motor neuron side, and flexion is normal response. Now, gait also is a part of motor system examination. What do we see when we assess gait? First of all, ask the patient to stand up. Note the stance first. Ask the patient to stand and stabilize themselves with their eyes open and with their eyes closed. Ask them to narrow their stance if they can stand with feet together, or they become they develop imbalance when their feet are together. Ask the patient to stabilize and ask the patient to walk in their normal manner to the end of the examination room and turn and walk. You have to observe for stability or tendency, whether gait is stable or the patient has tendency to fall in any particular direction. Is the arm swing present in the two sides or not? Steps, they are uh, the vertical distance is whether the distance between the step forward and step backward. The step behind and the forward step is the vertical distance, and the lateral distance is the step between the 2 feet. So you look for uh, vertical distance. If reduced, you call this short step gait, and lateral distance, if it is more, you call it broad base gait. So you also look for tilt and rotation of the pelvis. In another lecture on abnormalities of the gait, we will be talking about why do we look for tilt and rotation. It is difficult to make you understand with the slides, but we can help that with the help of the videos. So difficulty in initiating or stopping gait, any involuntary movement, and which is present while the patient is walking. Um, For example, in Parkinson's disease, patient has difficulty in initiating the movement. Patient appears initially glued to the floor or may sometimes stop, and then again this is difficult for the patient to stop. Sometimes during walking you may see involuntary movement because his hands are at rest, and we all know that Parkinson's disease is associated with rest tremors. We can see that rest tremors are present while the patient is walking. And we also look for turning. Patients who are unstable or who have this extrapyramidal disorders or disorders of tone, they do not turn as smoothly as normal people do. They turn in steps, or they have maximum tendency to fall during turning. So you look for turning specifically. So these are the specific points which you look for uh, uh, when the patient is walking. These are three small maneuvers, which with the three important maneuvers which we ask the patient to do. Ask the patient to heel walk when the patient is coming towards you, so that you can see that the 2 feet they dorsiflex equally, and this checks for any presence of any foot drop. So foot drop may be called maybe upper motor neuron type, or it may be lower motor neuron type, peripheral neuropathy, L5, cortical foot drop. So this just walking on heels detects presence of foot drop. Then you ask the patient to walk on toes when the patient is going away, so that you can appreciate that both heels are elevating at the same level. This checks for muscle weaknesses and also look for S1 radiculopathy. Then you ask the patient to do tandem walking, ask the patient to walk on a straight line with the heels of the foot in front, touching their toes of the foot behind. This is how we do tandem walking. This detects cerebellar ataxia, and when the patient is ataxic, will not be able to perform this gait. Gait abnormality, sorry, Gait abnormalities include hemiparetic, ataxic gait, shuffling, Parkinsonian gait, steppage gait, which is seen in long fiber neuropathy or neuropathy, and spastic or seizure gait, which is seen in upper motor and bilateral upper motor. Here are links to the videos. I can let's see. We do not have in fact time to show. I have videos uh, with me, uh, but I think we are not left with enough time. But I can just see if we can. If I can. Okay. What I would do, I would let you copy. I would hold my screen at this slide, so that you can copy, because we I have been because we do not have enough time. You can copy these links, and some of you copy this link, some of you copy this link, some here, and then share. So that you should. And these videos are available on YouTube, and they are teaching videos. You can share uh, with your friends these links, and can see the examination and we have discussed today. And one important reminder for all of you to pray for your parents. Thanks. Allah Hafiz.